All right, panelists, please come forward. Okay. All right, thank you so much for joining us today. I want to really thank you for taking time to invest in learning more about inflammatory bowel disease for yourself, investing in yourself, and also in those of your friends and family, your loved ones. Thank you for also supporting our program here at the Crohn's and Colitis Foundation. We have a really exciting time to ask the experts themselves very directed, specific questions. So keep bringing your cards forward or having them brought up here during this time. Feel free, don't be shy, you can just bring it up to me. Okay. And what I'm going to do is I'm going to take a representative few. We can't go through all of the questions in the interest of time, but what we will do is we'll try to answer the more general, repetitive questions, and then we'll allow you time either at the end of various sessions or at the end of the day, or in between sessions basically, to ask the remaining questions of the speakers themselves. So I'd like to introduce myself. I'm Dr. Jennifer Choi. I'm a gastroenterologist and IBD specialist over at Kaiser West Los Angeles. And at this time, it's my distinct pleasure to have our panelists introduce themselves and say your name and where you came from. And we'll start off with you, Dr. Ha.
Hi, my name is Dr. Christina Ha, and I am part of the Cedars-Sinai IBD Center.
Hi, Eric Vasilauskas. I'm part of the IBD Center at Cedars as well.
Hi, I'm Caroline Wong. I'm the director of the IBD program at the University of Southern California.
And as you know, I'm Emma Meyer from UCLA, the director of the Center for Neurobiology of Stress and Resilience and member of the Digestive Disease Division.
Okay, the first question is for Dr. Mayer, okay? Given the brain-gut connection, have there been any recent studies that show whether meditation might potentially contribute to remission in IBD patients?
So, I mean, just to clarify these medications in terms of if, on one point that I did not mention, I mean, there's an implication of the brain-gut microbiome interactions for the treatment with traditional, IBD medications, including biologics. I mean, it's a good example that the kind of immediate or very rapid subjective improvement of symptoms with TNF-alpha antibodies, for example. And I think we know the mechanisms pretty well because they act, this is not related to an improvement of the inflammation, but it's the effect of the antibody on endothelial receptors at the brain that decreases this immune activation within the brain that's present probably in many or subsets of IBD patients. So there's clearly an interaction of the traditional medications that we have with that system. I don't know if that answered the question.
Okay, and I'll bring up a different question. Should IBD patients take serotonin supplements? Will that help in any way with anxiety and depression?
Yes, and I've been asked this question several times in the break. I don't think there's good studies on it. I mean, it's kind of interesting that the serotonin system in the gut has received relatively little attention in terms of therapeutic approaches, even though quantitatively it's so much bigger than any serotonin cells within the central nervous system. I mean, there is not really high-quality controlled evidence that these supplements, the way they're available today on the internet, have beneficial effects on bowel movement, regularity, and well-being. But I'm not sure, if this would hold up to any sort of controlled studies. I mean, there has been, as probably people know, there has been a sort of a negative press on these supplements some 10 or 20 years ago, but that really was resolved because it was not the tryptophan supplement itself, but the ingredient that was in these preparations that caused this serious side effect. So I would say it's not dangerous, it's harmless. I've had several colleagues who've taken it experientially, and I would do the same thing. I mean,
Okay. How about, are there any specific dietary recommendations any of the panelists recommend for patients with Crohn's disease or ulcerative colitis? There's a lot of interest in asking specifically about the specific carbohydrate diet, in particular, SCD diet. Can anyone share your experiences in IBD patients with that?
Well, I'm going to be talking specifically about that with slides in a little bit. So, and then I believe our dietitian, Kelly, is also going to be discussing that. So we'll go into that in detail at one of those 2 sessions.
Okay, great. So stay tuned for more. Okay. All right. Are there, let's see, any benefits to drinking pH-specific water in IBD patients? That's a very specific question.
I'm not aware of any definite data with that.
Okay.
I mean, this always comes up. So I mean, I have to say through my book, I've been involved in or gotten invited to many of these functional medicine meetings. I'm sure there's quite a few people in here who've been involved with that too. I mean, it's kind of amazing. It's like a parallel universe where many things that lack the solid scientific evidence are being promoted pretty aggressively and in a holistic fashion. A lot of people are following this, so alkaline water is definitely one of those interventions that are being presented at these meetings. But as you said, there's no controlled data really on.
Are there certain situations in which you might recommend certain probiotics for IBD patients?
Are you going to be covering that too?
I specifically, I mean, there are studies that suggest it can be helpful for like chronic pouchitis. I think there's good data there. The data has been very kind of all over the board when you look at the various studies. One of the problems is that a lot of the studies that are done with preparations that are sort of like unique to that group, so you can't go out and buy it, at a store someplace. And so the findings that you have in a given population may not really be translatable to what you can find on the shelf someplace. I do actually use probiotics a lot in the setting of patients who also, in addition to their Crohn's or colitis, have small intestinal bacterial overgrowth, or SIBO. I find they can be very helpful there, but that's just my personal experience, not based on a specific study.
Great.
I mean, I would comment on this. I think it's the probiotic field in general. And again, if in the functional medicine community, all kinds of magic super probiotic combinations are being promoted. I think until we really have a detailed characterization of the gut microbiome in healthy people and in different subtypes of disorders and diseases, it's an empiric treatment that a lot of the patients will already have tried anyway by themselves. And I don't think we have the data to really specifically intervene based on hard science right now.
Okay.
I think it's an intriguing field that requires obviously further exploration, but we also have to think about costs. And the costs of managing Crohn's disease, ulcerative colitis, the sequelae of both are pretty astronomical. Probiotics are oftentimes not covered by insurance, and if there's a limited amount of resources, it may not, at this juncture, with the amount of evidence that we have, be worth the additional financial burden if it's a matter of paying for probiotics versus another treatment that may have better therapeutic efficacy.
The one area where it might make sense, though, is in someone who has had, say, C. difficile, and it's an infection you get usually from taking an antibiotic. So if someone's had C. diff, you may want to consider taking probiotics of various forms, including there's a variety of them out there, Saccharomyces boulardii and such, because they might help prevent you from getting another episode possibly. But again, it's more based on personal feelings than actual data.
So do medications suddenly stop becoming effective or stop working? That's a question that has been echoed throughout many of these cards. Dr. Ha, we'll ask you.
Okay. So, there are, There are obviously a host of circumstances where medications can appear to stop working. I think the easiest example is to look at medicines such as the biologics, like the anti-TNFs, like Remicade, Humira, Simponi, Cimzia, et cetera. And it's because the nature of these medicines, over time you may be at risk, depending on your dose, your disease activity, your interval, for developing antibodies to these medications or adverse reactions to the medications. So that may be one reason why the medications stop working. Another, which is probably more common, is that your disease activity probably has progressed beyond what these medications can do. So for example, for a class of medications called the aminosalicylates or their mesalamines like pentasa, azole, or sulfasalazine, let's say your ulcerative colitis activity persists after years of, starts to increase after a few years of doing well on one of these agents. It may be that your disease activity has progressed beyond what that level of medication can work. So if you start to notice or you're starting to become concerned that your medications may not be working, it's certainly worth an evaluation, a conversation with your physician for some lab work, stool studies, maybe even a quick look. One of the ways to help to make sure that your medications continue to work is to take them and to continue to take them, and also make sure that you're following up with your clinician, because oftentimes when they start working, that's when you miss the office visit, you don't check the labs, or you skip the scope because things are going well. So that's, those are some scenarios where they may stop working.
Go ahead.
Thank you. You mentioned about antibodies with Remicade. Is the antibody, is there a better chance of reducing that antibody probability if you take methotrexate with the Remicade, or is that, I mean, if you've been on Remicade for, let's say, 8 years, if you suddenly start taking methotrexate for that, then you have a better chance of it lasting maybe another 8 years, or is it just going to take its course regardless?
Well, I think that
So let's rephrase or re-ask the question. So if she uses methotrexate in addition to Remicade, will that help in any significant way?
Well, I can start, and then I'll defer to the rest of the panel to add in their input as well. I think that there is increasing literature that having a combined therapeutic approach, so you use a medicine like an anti-TNF with something, especially Remicade, because it tends to be, it's part mouse and part human, and there is a risk of forming antibodies. Up to 40% of people can develop antibodies over time when it's used by itself, or more importantly, when it's used episodically, so every now and then rather than consistent dosing. Ways that you can decrease antibody formation is to make sure you're taking your medications at the right scheduled intervals, at the right dose. But the idea behind using something else, whether it be methotrexate, azathioprine, or mercaptopurine, is to a certain degree to decrease the potential of forming antibodies. Now, does it work 100% of the time? No. And so in terms of if you've been on a stable dosing of your particular medicine, let's say, for example, Remicade, and then you have a flare, and then methotrexate, as an example, is added, we have to, in terms of what it does, we have to ask, well, why was the methotrexate added? Was it because your Remicade levels were low and you didn't have antibodies, and we wanted a way to actually boost your Remicade levels so that they can continue to work? Or is it because something new developed and you needed a different mechanism so that they could work together to make things, make the disease activity better controlled? So for example, if you had new perianal disease. So it really depends on the context as to why it's added if you were on an original therapy, but depending on how aggressive the Crohn's or the colitis is at the time where the discussion of starting these agents are, a lot of physicians nowadays are advocating starting 2 at the onset.
But that also goes to the point that in the very beginning of a flare is probably when that has the most impact, because these drug levels go up and then they go down very rapidly. So it may not last the entire cycle before you get your next dose, in which case the immunosuppressive is kind of helping you not make antibodies to it. Whereas in someone who's been on, say, a drug for one of these biologics for, say, 7 years, and we can actually measure drug levels now and antibody levels. And so if your drug level is fine and you don't have any antibodies, then there may be there's no definite benefit at that point of being on combination therapy, and maybe a single agent would be totally fine. So it really depends on the specific situation. As a general rule, yes, it's beneficial. Is it needed in all situations? probably not. I have a lot of patients who do monotherapy for a variety of reasons. So it just depends on the context of the specific situation.
Yeah, your risk of developing antibodies is the highest in the first year of treatment, and so once beyond that, if you're in remission, your risk of antibodies does go down over time.
And then let's say you do start losing effect, as you're talking about over here, then sometimes, and you have some antibodies there. If you add, or you have, say, a lupus reaction or something like that from the drug, sometimes if you then add in an immunomodulator like methotrexate or 6-MP or azathioprine, that may go away over time, so, or you can even sometimes just give the dose more frequently, go up on the dose of the biologic and overcome that as well. So it's, there's no one scenario fits all.
Is it safe to ever use dual therapy using 2 biologics?
So it's not usually the standard of practice to do that. It gets kind of complicated. I mean, there are some biologics, for example, that are used for treat osteoporosis, and people are maybe on an IBD biologic and, say, an osteoporosis biologic at the same time. When we're prescribing biologics, we tend not to do that. I mean, there would be, it's been looked at in a few small studies. There might be some specific scenarios in really refractory patients where one might consider that, but that would be like on a very specific, small case-by-case basis, and the theoretical concerns of immunosuppression are super high in that scenario. So it's not something that is routinely recommended, certainly.
And for follow-up, what is the recommended washout period that you usually adhere to? So between the 2 biologics then?
I would say it depends on the scenario again, because, for example, with the anti-TNFs, like Remicade, Humira, when there's lots of inflammation, the drug may not even last a week in your system, and whereas when you're in remission, the drug may last 12 plus weeks. So if someone's switching because they have lots of inflammation, you might not have to wait more than a week to start your next biologic. If someone is just switching because they're having some sort of other minor, not minor reaction, but a reaction that's kind of limiting the use of the drug, but their disease is controlled still at that point, then you probably want to wait longer before you switch. Yeah, so it just depends.
And this is where also sometimes we may check your levels, because if you don't have any levels of that particular medication in your system, then we can more likely than not start the next treatment relatively soon, particularly if you're feeling pretty unwell. But if you have high levels of an agent and in your system, let's say you have high levels of, we keep using Remicade only because Remicade levels have probably been around the longest in your system, before adding another immunosuppressive agent, because of the concerns of infection, we may want a little bit of a longer washout time. But if you're very symptomatic, in the interim, we may need to do something like add a course of steroids. So it's always, you're going to hear this theme over and over again, that decision-making is very individualized based on the scenario. So it's hard to give overarching, generalized recommendations, but those are sort of the principles we follow.
What is the longest period that you would recommend for steroids?
As short as possible. 1 course.
That was my answer. Wait a minute. Yeah, no. Yeah,
Tell
I
us
totally
about
agree.
this. Tell us about, so for people in the audience who don't know, tell us about some of the side effects or the concerns with using corticosteroids.
Okay. So there are multiple side effects from the use of steroids, or the most common one being prednisone that is prescribed. They're very effective in the short term, potentially for decreasing inflammation. But the problem is that oftentimes we know that patients historically have become dependent on them. So with repeated courses or not able to taper off for a long period of time. And so major side effects, it causes the most infections of any medication that we have, including any of the biologics, risk of decreased bone density, increasing your risk for osteoporosis and premature hip fractures and other kinds of fractures in your body, diabetes, high blood pressure, early cataracts, weight gain, skin changes, increased wound infections. The list goes on and on.
But what I would like to say is no one would argue that you want the shortest course of steroids possible, but if you needed the steroids to get your symptoms under control, you need to be on it at least long enough for Plan B, which is your steroid-sparing regimen, to work. So it's not as though you can necessarily be on prednisone for 3 days and stop while waiting for, let's say, Entyvio, Humira, Remicade to work. You need to at least make sure you're tapering off it at a rate so that you have enough time to make sure your steroid-sparing strategy will work. So when we talk about as short as possible, we oftentimes mean we don't want you to receive course after course of steroids before doing something different, but we also don't want you to be on a dose of steroids, let's say 20 milligrams for 6 months, because then that means that our alternative strategy is actually not that effective, right? Because you're still on the steroids.
So steroids work quick, they can work very well, but you always want an exit strategy. So you need to have that in mind when you start a course of steroids. You know, how are you going to get off the steroids?
All right, let's transition over and talk about surgeries for Crohn's disease. So if you've had surgery for Crohn's disease, what's the likelihood that you're going to need another surgery?
Well, there is data from like the pre-biologic, pre-immunosuppressive era, which shows that without any sort of real strategy or long-term medication use, in the old days they used to sort of just not use medicine on a regular basis, that like over 90% of patients with Crohn's would end up having surgery within 30 years, you know. And they looked at recurrence data, and somewhere in the realm of about 70% of patients end up having a second surgery without medication. And so Crohn's comes back. So again, if you can have surgery, it can be a nice quick fix for things. Very often it's the right thing to do, but you need a long-term strategy to prevent things from coming back. And that long-term strategy usually involves some sort of medication, and then looking inside afterwards to really try to catch things early. But with a good exit plan and good post-op treatment strategies, we've looked at our data here, and our surgical recurrence rate is in a realm about maybe 6%. Probably half of those are patients that didn't really do what we recommended and ended up having a second surgery because they didn't really follow through with things, but then they had a second chance, or third chance, I guess, at that point.
And I think that that's really the key, is that while a lot of people with Crohn's disease may end up having an initial surgery, in terms of what can you do to decrease your potential risk for additional surgeries, first is if you have a history, if you're a smoker, you have to stop smoking, because smoking will increase your risk. But also, again, this is another theme you'll hear over and over again, you have to follow up, because you're probably going to need to be on some form of treatment if you required surgery. But more, also just as important, someone's going to need to take another look, either 6 months, 12 months after your surgery, because the recurrence is actually pretty silent. So you'll have endoscopic recurrence. So you may see it on the scope well before you start to experience the symptoms. And the tricky thing is by the time you start to develop the symptoms, you're really behind the 8 ball, so you're playing catch up. So the idea is try to be proactive rather than reactive.
I mean, the one really neat thing about surgery for Crohn's disease, where you're resecting that last part of the small intestine there, is that, we always wish we had a crystal ball, in talking to patients. And I'm sure many of you wish we had a crystal ball too, But surgery is the closest we have to that, because we can see stuff inside. It's, say 6 to 12 months that predates the actual development of symptoms most time by maybe a year or two. And so by looking inside, we can actually tell before someone has symptoms if whatever they're doing is working well enough or not, and it's a chance to really intervene. And if you think about it, the small ball is maybe about this big, and someone may not become symptomatic until they get down to about that, which is pretty small. It's about the size of my pen tip. And so it can really sneak up on you. And if you're not proactive after surgery, you may be looking at another one.
So this question is for Dr. Mayer. Is what you described this morning actually irritable bowel syndrome? And if so, what is the difference between irritable bowel syndrome and what you're describing? If not, what is the difference between the two?
I mean, this is a very good question, and there's no definitive answer. I think there's two possibilities, as I mentioned this morning. One is that, and that's quite likely, that because of the prevalence of 10-15% of IBS in the population, that there's patients that have both IBD and IBS, so it's a accidental coincidence that you have both of those disorders. So when your inflammation goes, well, two things will happen in that case. One is you'll have more symptoms from the same amount of inflammation, and B, even when the inflammation heals, then you will still have the symptoms. The other possibility is, there's lots of animal models that have shown if you cause a chronic inflammation of the gut, that it changes all the nerves, the vagal innervation, the spinal innervation, all the way up to the brain during the inflammation. In animal models, some of these changes persist even once complete healing with inflammation. So it's conceivable that the inflammation actually causes this, what we refer to as visceral hypersensitivity, and that sets you up for these symptoms even when the mucosal healing has occurred. And those changes can happen in the peripheral nerves, the spinal cord, or at the brain level. I think it's these kind of symptoms in Crohn's patients are too common to just be explained by the by the coincidence of IBS or by comorbidity of IBS with IBD. So it's like they're like 3 times as high as they would be with IBS alone.
Are there any recommended exercises that any of the panelists share with our IBD patients?
I'll be talking about that shortly.
Okay. To be continued. Okay. All right. Another question for Dr. Mayer. Can you elaborate on the early life programming and motivation and resilience?
Well, I mean, I showed these 2 circuits or networks that we know pretty well, like the dopamine-driven, reward circuit, which is like behind the motivation, and resilience, where we understand it less. I mean, the main part of that is how your prefrontal cortex can control the emotional and stress circuits that are lower. How that happens, there's a lot of there's epigenetic phenomena that's been really well studied in animal models. The early life stress model, maternal separation. You take the pups away from the mother. The mother's stress becomes a negligent mother, and then the pups develop these epigenetic changes in their stress system, like the glucocorticoid receptor, and that persists. So after this programming, it persists throughout life. In theory, epigenetic changes are reversible and will be at some point therapeutically, but right now, I think there's a lot more we know about that phenomenon of early life programming of the nervous system, the stress system, than we know about the microbiome programming. But I think we know about the stress system. Resilience is a whole other thing that has been, like many positive or health promoting things in medicine, have not been studied in detail because the NIH does not fund studies about health and positive things. So, so we know very little. There's been a recent interest in psychiatry of what these resilience mechanisms are in the body and how they're shaped, probably also early in life.
All right. Can our panelists tell us if they have experience with the fecal microbiota transplantation or fecal transplants?
I have experience with fecal transplants in the setting of C. diff infections that happen at a higher rate in inflammatory bowel disease patients. But I think outside of that, as primary treatment for inflammatory bowel disease, I think fecal transplants generally should be done within a clinical trial. Because there have been very mixed data. There's been positive studies and negative studies, even though there's a lot of interest, just like with probiotics, that we know that the microbiome is really important in IBD. But as to, I think part of it is just like we don't know which microbiome we want to target for every individual IBD patient with a probiotic. The same is true with a fecal transplant. We don't know what kind of bacteria is good for one person is definitely going to be good for every IBD patient.
Yeah, this is a general dilemma now, and it's being addressed by a lot of entities, commercial and scientific, of what I mentioned, to apply machine learning and artificial intelligence on very large numbers of patients to extract subtypes of patients who have distinct patterns of the microbiome, for example, that will respond to different therapies. So I think in the next 5 years we'll definitely have these answers.
And the thing is, we don't really know either, like, what is, the best kind of microbial composition to give to somebody. Remember, with a fecal transplant, you're not reestablishing your own microbiome. you're getting someone else's, and that may or may not end up being a good thing. I know of 2 patients, I mean, the data again is sort of all over the board, but I know of 2 patients that were feeling well, thought a fecal transplant would be a really cool idea, and ended up flaring so bad they needed surgery and have their colons out. So they're not posting on the internet how wonderful, FMT is, but these things do happen, and the other thing is that, you're not just transferring like bacteria with this. You're transferring, viral particles, you're transferring, fungi, you're transferring other microparticles that may have other long-term health consequences as well. So it's just, it's super intriguing, but it's not ready for prime time, at least not yet.
Also, one comment to this. So, I always like to compare it to what happens in natural ecosystems, because clearly our microbiome is an ecosystem. And if you look at what happens if you have invasion of non-native species, so there has to be, like, the ecosystem restoration requires initially to get rid of everything and then restore it from scratch. So this happens automatically in condition like C. difficile because you knock out most of the normal environment. There are now some attempts, I know it from autism spectrum disorder studies, where they basically do repeated and prolonged broad spectrum antibiotic treatments before they start the transplant. So that's another approach I think that will probably be looked at.
Okay, final question. Tell us if you recommend marijuana, cannabis, or CBD oil in your patients.
Dr. Ha's specialty.
Why is it my specialty? It's LA's specialty, isn't it? I think that the data with respect to marijuana as a primary treatment for Crohn's disease or ulcerative colitis, meaning to actually heal the lesions, heal the mucosa, make an inflamed area normal again, not only in terms of clinical symptoms, but when we look at it with a scope, when we take biopsies to normalize inflammation is somewhat lacking. I think that the science behind it is somewhat intriguing, but where I use it for some patients is to help as an adjunct for certain symptoms. So for example, if they have an area of narrowing and we're starting a new treatment, and nausea and weight loss and appetite stimulation is really important, are important areas that we have to address as an adjunct. I'm not opposed to that, for example. But you have to keep in mind with cannabis, just like any other prescription medication, as an example, there's a ceiling of how much you can use before it starts to react against you. So while the idea of marijuana has a lot of appeal in terms of symptom relief, I think as a primary treatment, the data is lacking. But as an adjunct, as long as it's used carefully, I think, for example, in my opinion, it's better than being on chronic narcotics.
Yeah, I would agree with this as well, and make a comment. The reason we don't have these answers is because any research has been blocked for the last 20 years for political reasons. And I think if that, hopefully will change, certainly, hopefully in California, then I think we will have answers on that, because clearly those CBD, the CBD preparations without the hallucinogenic effects of THC, I personally think have a great promise on many aspects: inflammation, the pain, the anorexia, that we just don't know.
I used to, when I would scope people, we ask kind of, do you smoke, stuff like that, and about 10 years ago, it went from no to like, well, not cigarettes, and and now people just come out and say, yeah, I use medical marijuana, So, we've had patients, a lot of our patients have used marijuana recreational or medicinally. I think it can help with symptoms, with some specific symptoms that way. In terms of like actually addressing inflammation, there's probably anecdotal things out there, but honestly, in terms of like when I scope people to look for actual healing, I just haven't seen it yet. And I scope plenty of patients who wouldn't be poster children for the positive beneficial effects of marijuana on their IBD. because it's pretty inflamed inside there despite, relatively frequent heavy use.
And what I will say is some of the initial studies actually looking at marijuana use, just even from a survey study, and then following it up with endoscopic or clinical symptoms, is that a lot of patients who used marijuana, they were less likely to be adherent to their conventional treatments because they would use it as a substitution rather than an adjunct. And in a couple of studies, the surgical rates, surgery rates, hospitalization rates, and endoscopic worsening rates were greater. So it's just a matter of how you use it, as an adjunct versus a substitution. As an adjunct, it may have benefit, but as a substitution, probably not.
And the other way of looking at it too is that, does it cause harm? And there I can say, cigarettes we know cause harm. I can't say that, I haven't actually seen that with marijuana, so I'll just kind of throw the flip side out there.
Okay.
Also, one comment about Tina's observation in these epidemiological studies. So a lot of people that use marijuana take it because they have elevated anxiety or psychological symptoms. So they may have a higher risk of having more complicated courses of the IBD anyway, and this may be a false association. So I think until we have really controlled placebo-controlled clinical trials with some of these newer compounds, I think it's really hard to say if it's good or bad for you.
Well, join me in thanking our panelists. We're going to go ahead and break out into our next sessions shortly. And we couldn't get through all of your questions, but feel free to keep sending your questions forward, and we'll do the best that we can to either incorporate them into future programming or making sure that we get your questions answered at some point. Thanks.